All right, let's jump right into a deep dive into neurology. But we're not cracking open textbooks today. We're going right into the action with paramedics facing those real-life neurological emergencies.
Exactly. Using these really interesting case studies, it'll be like we're right there with them, having to think fast and make critical decisions under pressure.
Exactly. So imagine you're on duty. It's a Sunday morning, kind of chilly, and you get called to a church. An elderly man there suddenly can't speak, and one side of his body has gone weak. Wait, what are you thinking?
Well, those are some major red flags right off the bat. Sudden speech problems and weakness, especially on one side. It's going to make you think stroke.
Makes sense. Every second counts when you're dealing with the brain, right?
Absolutely. You want to limit that brain damage as much as possible.
Now, the report says he's conscious but confused, drooling a bit. His pulse is strong but irregular. And the big thing, he can't speak at all and his awareness is way off.
Okay, so you're on scene. What's the first thing you're doing?
Well, I'm thinking ABCs, right?
Mm-hmm.
Airway, breathing, circulation.
Spot on. Always got to make sure those are good.
And in this case, the source material really emphasizes making sure he's getting enough oxygen, especially since he's not fully aware of what's going on.
Yeah, that makes sense. Brain cells are incredibly sensitive to not having enough oxygen. Even a little bit of time without it, and you can have serious damage.
Now, to add to the stress, his blood pressure is through the roof, 240 over 118.
Whoa. Yeah, that's definitely another piece of the puzzle. High blood pressure or hypertension is a major risk factor for stroke. It can really do a number on those blood vessels in the brain, making them more likely to get blocked or even burst.
Speaking of different types of strokes, the source material asks, what are those two main categories? And what's the go-to treatment if someone have an embolic stroke?
It's all about those blood vessels. Think of it like your brain's plumbing system. You can have a clog, which is an ischemic stroke,
Hmm?
or a burst pipe, which is a hemorrhagic stroke.
Oh, so like a plumbing emergency in the brain.
Yeah, pretty much. And for that embolic stroke where a clot travels to the brain, the source talks about clot-busting meds.
So a burst pipe situation, that's got to be a rush to get him to a surgeon, right?
You got it. And with those clot-busting drugs, they only work within a specific time frame. That's why getting a patient to a stroke center fast is so important. They can figure out what kind of stroke it is and give the right treatment, whether it's meds or surgery.
Okay, new scene. We're called to a restaurant. A young woman has just had a seizure.
Witnesses are key here. They can give you so much info about what happened during the seizure.
Right. And this witness says she just looked at them briefly when they called her name loudly and that she peed herself.
Yeah, that's pretty common after a seizure. So you get there, what's your first move?
Well, safety first, always, right? Seizures can be unpredictable. Got to make sure the scene is safe for me and the patient. And then back to the ABCs. Airway, breathing, and circulation.
Exactly. While you're checking that, you also want to get as much info as possible about what happened during the seizure. Like how long did it last? What kind of movements did she have? Does she have a history of seizures? All that's important.
The source material asks about the different phases of a tonic-clonic seizure. You know, what some people call a grand mal seizure.
Right. The one that comes to mind when most people think seizure, loss of consciousness, the whole body convulsing. But it's not just one thing happening. It's not just going on and on. There's that tonic phase where the muscles tense up, then the clonic phase with the rhythmic jerking, and after all that, the postictal phase where the person might be confused and drowsy.
So there's like a beginning, middle, and end to it.
Exactly. The source also mentions status epilepticus. That's when the seizures last a long time, like more than 5 minutes. Or they happen one after another without the person coming back to normal in between.
That sounds really scary.
It definitely is. It's a real emergency, can be life-threatening. And for adults, the most common cause is people not taking their anti-seizure meds like they're supposed to.
Okay, a good reminder to always follow doctor's orders. All right, case number 3. We're called to a busy shopping mall. This time, it's a woman experiencing dizziness and weakness, but on her left side. And here's the thing. Her eyes are moving back and forth really quickly.
That sounds like nystagmus, involuntary eye movements. Could mean there's a problem in the inner ear or in the parts of the brain that control balance and eye movement.
Now, her medication list is a mile long. Mevacor, Altavin, Celebrex, and Feldene.
So she's dealing with cholesterol, anxiety, and pain. Interesting to think about whether any of those meds, or maybe how they interact with each other, could be causing her symptoms.
And this is where it gets really interesting. The source mentions a possible diagnosis of Wallenberg syndrome.
Wallenberg syndrome, let's see. That's caused by a stroke in a very specific part of the brainstem. The brainstem is that connection between the brain and spinal cord. It's pretty rare, but it can cause dizziness, problem swallowing, that nystagmus we talked about, and weakness or numbness on one side of the body.
The brainstem controls, like, all the important stuff, right? Breathing, heart rate.
It's like the command center. Even a small stroke there can cause a ton of problems.
Okay, last case for this round. We're called to a home where a woman has a really bad headache on the left side of her head, and the report emphasizes that the pain is throbbing.
Throbbing pain, especially on one side, makes you think migraine, right?
Yeah, the classic migraine. But here's a twist. The report also mentions she's been using a Nicoderm patch.
That's interesting. Nicotine withdrawal is a known headache trigger, so maybe it's not a typical migraine after all. Maybe it's related to that.
So it might not be as straightforward as it seemed at first.
Exactly. There could be a lot of factors at play.
And while we're talking about headaches, the source mentions other types to keep in mind, like tension headaches. And those cluster headaches, yikes, those sound awful.
Each type has its own unique characteristics, and they can be caused by different things.
So we've got 4 cases, 4 neurological mysteries to solve, ready to dig in.
Absolutely. Let's break down each case and see what other clues we can find.
Okay, back for more. Let's go back to that first case, the elderly man with the possible stroke. We're thinking stroke, but we got to look closer.
Right. Remember we talked about those 2 main types? Ischemic, like that blocked pipe, and hemorrhagic, like a burst. The source material actually gives us a whole list of stroke symptoms to watch out for.
Okay, so we've got facial drooping, confusion, agitation, trouble speaking, weakness on one side, unsteady walking, and altered consciousness. That's a lot.
Yeah, it is. And the thing is, the specific symptoms can be so different. It all depends on where in the brain that stroke happened and how bad it is.
That makes sense. Now, what about his medical history? The source material gives us a whole rundown of his meds.
Oh yeah, that medication list. It's like a sneak peek into his overall health. You can see what he's dealing with. So he's on meds for hypertension, atrial fibrillation, and diabetes.
Wow, so he's managing high blood pressure and irregular heartbeat and diabetes. Those are all things that make a stroke more likely, right?
Absolutely. Uncontrolled hypertension, atrial fibrillation, and diabetes, those are all big risk factors.
The source material lists a bunch of medications. Atenolol, digoxin, albactone, Lasix, spironolactone, Humulin N, Humulin R, Tufenil, and Mobic. It's a lot. Do paramedics really need to know what all of them do?
Well, it's like having a cheat sheet, you
Right.
know? It helps you understand the patient's story. Like seeing those insulin names tells you right away, okay, diabetes is part of this.
Now back to the stroke itself. The source material asked about how to treat an embolic stroke, and we talked about clot-busting meds.
Yeah, but remember, it's all about timing. Those meds only work within a certain window. That's why getting them to a stroke center ASAP is so, so important.
So it's a race against time to save that brain tissue.
You got it. The source material also asks about the difference between a stroke and a TIA. A TIA is a transient ischemic attack.
I've heard those called mini-strokes.
Yeah, that's a good way to think about it. It's like a temporary interruption in the brain's blood supply. You get those stroke-like symptoms, but they usually go away within 24 hours.
So even though the symptoms go away, it's still a big warning sign, right?
Definitely. It's like a red flag that a full-blown stroke could be on its way, like your body is trying to tell you something.
All right, on to case number 2, the young woman who had a seizure at the restaurant. We know those tonic-clonic seizures have those distinct phases: tonic, clonic, and postictal.
Right, stiffening, jerking, and then that period afterwards where they might be confused and out of it. The source material brings up something called an aura.
An aura, like a warning sign before the seizure.
Exactly. It's a sensory experience some people get before a seizure starts. Could be a weird smell, a strange taste, seeing things that aren't there, even a feeling of deja vu.
So it's like their body's giving a heads up.
Yeah, like something's about to happen. Now, the source material also talks about status epilepticus again. Remember, those are the prolonged or repeating seizures, the ones that are really dangerous.
And we know that for adults, the most common cause is not taking their anti-seizure meds.
That's right. The source material also asks about the different meds paramedics might use for seizures in the field.
I imagine there are a lot, considering how many different types of seizures there are.
Yeah, there are quite a few. Broadly, they fall into categories like barbiturates, hydantoins, benzodiazepines, and others. Each type works a little differently to stop those seizures.
So it's like having a whole toolbox with different tools for different jobs.
Exactly. And choosing the right med depends on what kind of seizure it is, the person's medical history, and other stuff.
Sounds like managing seizures is really individualized.
It definitely is. It's complicated and always changing.
Okay, let's move on to case number 3. Remember the woman at the mall? Dizziness, weakness on her left side, those weird eye movements. The source mentioned Wallenberg's syndrome.
Right, and remember, it's pretty rare. It's caused by a stroke in a very specific spot in the brainstem, that lateral medullary area.
That area must be pretty important.
Super important. It controls things like breathing, heart rate, and how we process sensory information. Even a little stroke there can cause a whole bunch of problems.
No wonder she was having so many different issues. What else might you see with Wallenberg syndrome?
Well, besides what she had, you might see nausea and vomiting, trouble swallowing, maybe hoarseness, problems with balance and coordination, even hiccups.
Hiccups. That's weird.
It might seem strange, but the brainstem actually helps control hiccups, so if there's damage there, it can mess that up. Just goes to show how connected everything is in the body.
Fascinating. The source material also asks about cranial nerves. Can you refresh our memory on those?
Cranial nerves are like direct lines from the brain to different parts of the head and neck. There are 12 pairs, and they're in charge of all sorts of things. Facial sensations, eye movements, taste, hearing, even shrugging your shoulders.
Wow, so they do a lot.
They do. And in Wallenberg syndrome, certain cranial nerves can get affected, like the trigeminal, glossopharyngeal, vagus, and accessory nerves.
So that explains why someone with Wallenberg's might have trouble swallowing or have a hoarse voice. The source material also mentioned another name for this condition.
Oh, right. It's also called lateral medullary plate syndrome. Same thing, different name.
Gotta love those medical terms. Okay, on to our last case. The woman with that intense, throbbing headache. We were thinking migraine, but she was also using that Nicoderm patch.
Right, and we know nicotine withdrawal can trigger headaches, so maybe it's not a classic migraine.
The source material asks what kind of signs you might see if movement makes the headache worse.
Well, she said the pain got worse when she moved, especially when she was up and about working at her computer.
So moving around made the headache worse.
Exactly. And that can be a red flag that something more serious is going on, especially if it's new or if it comes on suddenly.
Definitely something to get checked out. Now, the source material also asked about the types of meds she's on.
So we've got Tylenol, Zoloft, and that Nicodem patch, analgesic for pain, antidepressant, and a smoking cessation aid.
Right? It just reminds you that meds can interact with each other, and they can have side effects that might be contributing to what the patient's feeling.
Absolutely. That's why getting a complete medication history is so important. It helps you put the pieces together.
Well, we've gone back through each case and found some more clues. What are your thoughts?
These cases really show how complex neurological conditions can be. Even the ones that seem simple at first glance, it's like a puzzle. You got to figure out how all the pieces fit.
All right, final round. We've analyzed symptoms, looked at meds, talked about possible diagnoses. Now it's time to put it all together.
Yeah, like solving a mystery. We've seen how even the little things can be important clues when you're dealing with the brain. So let's go back to those questions from the source material and see what else we can learn.
Sounds good. In our first case, the elderly man with the suspected stroke, the source material asks about what his ECG rhythm looks like.
It's atrial fibrillation. Remember, his medical history included atrial fibrillation, which we know makes a stroke more likely.
Right, atrial fibrillation. Basically, the top chambers of the heart aren't beating right. They're just kind of quivering.
Yeah, that's a good way to put it. And because of that, blood can pool in the heart, which can form clots. And those clots can travel to the brain and cause a stroke.
So it's like a chain reaction, and the end result can be really bad. The source material also throws out this scenario. What if you find a patient unresponsive in bed first thing in the morning and you think it's a stroke? Would you activate a stroke code?
That's a tough one. The source points out that because we don't know when the stroke actually started, that patient wouldn't qualify for treatment under a stroke code. Those codes are all about time. There's a specific window for those interventions to work.
So if you don't know when it started, you can't be sure if those clot-busting drugs would still be effective.
Exactly. It just highlights why knowing the last known well time is so important for stroke patients. It's the last time anyone saw them acting normally, without any symptoms.
Okay, on to case number 2. The young woman with the seizure. The source material asks what kinds of meds paramedics use for seizures out in the field.
Usually benzodiazepines, like diazepam or lorazepam, they work quickly to calm that overactivity in the brain that's causing the seizure.
So like hitting a reset button.
Pretty much. They work by boosting the effects of GABA, a neurotransmitter that helps slow down those nerve impulses in the brain.
Makes sense. The source material also asks why someone might be confused after a seizure.
Could be a few reasons. During a seizure, the brain's going haywire and it needs time to recover to go back to normal. That can cause confusion, what we call the postictal phase.
So like rebooting a computer after it crashes.
Good analogy.
Yeah.
And on top of that, some seizure meds can also cause confusion as a side effect. And of course, if there's an underlying medical reason for the seizure, that could also contribute to confusion.
So lots of possibilities. Okay, let's move on to case 3. The woman at the mall, possible Wallenberg syndrome. The source material wants us to think about what causes this rare condition.
It comes down to a blockage of blood flow to a very specific part of the brainstem. Usually it's a blockage in one of the vertebral arteries or the posterior inferior cerebellar artery. Those are the arteries that supply blood to that area.
So like a traffic jam in the brain's highway system.
Perfect way to think about it. And the source material also reminds us that Wallenberg syndrome has another name.
Right, lateral medullary plate syndrome.
Exactly. Same thing, just a different name. Medical lingo. Gotta love it.
Okay, last case. The woman with that terrible throbbing headache. The source material asks for some typical signs that movement might be making the headache worse.
Well, she said the pain got worse when she moved around, especially when she was at her computer working.
So just the act of moving made the headache worse.
Right. And that can be a sign that something more serious is happening, especially if it's a new symptom or comes on suddenly.
Definitely something to take seriously.
Ah.
And the source material also asks about the different types of meds she's on.
She's taking Tylenol Zoloft and using a Nicoderm patch.
So analgesic for pain, antidepressant, and a smoking cessation aid.
Yep. And it's a good reminder that medications can interact with each other, and they can have side effects that might be adding to what the patient's experiencing.
So it all comes back to that thorough medication history like we've talked about.
Absolutely. It's such an important part of figuring out what's going on with the patient.
Well, we've covered a lot of ground in this neurology deep dive, from strokes and seizures to Wallenberg syndrome and headaches. We've really gotten a glimpse into what paramedics deal with in these real-life situations.
It's been a fascinating journey through the complexities of the brain, and even though we've learned a lot, there's still so much more to discover.
Absolutely. But one thing's for sure, rapid assessment and a good history are crucial when you're dealing with neurological emergencies.
Couldn't agree more. Every little detail matters, from the symptoms and vital signs to their medical history and what meds they're taking.
It's like piecing together a puzzle, and every piece helps you get closer to the answer.
And the more we understand about the brain, the better we can care for our patients.
So next time you come across a neurological case, remember what we've learned from these paramedics. Think critically, gather all the information you can, and don't underestimate the power of connecting the dots.
And keep learning. Neurology is always changing. There's always something new to discover.
That's right. Stay curious, and be sure to join us for our next deep dive, where we'll explore another fascinating area of science and medicine.
Until then, keep those brains engaged.